Retention. Retention of urine, whether acute or chronic, causes congestion of all that portion of the urinary tract lying above the point of retention. Thus, if the retention is in the urethra, both kidneys and the bladder are involved. If it is in one ureter only, one kidney is involved. The congestion is due to actual pressure of urine. Anyone who has seen a patient writhing in the agonies of acute retention of urine will not doubt its existence in acute cases. The congestion of the kidneys in chronic retention is shown by the reduction in the output of solids, notably of phenylsulfonephthalene. It is also shown by an acute congestion at the time of relief of renal retention, signalized by a marked polyuria. Albaran was the first to note that the evacuation of an intermittent hydronephrosis was followed by a period of polyuria from that kidney. A similar polyuria is a feature of grave prostatic retention. But even the slightest obstruction is quite capable of disturbing the normal physiological condition of bladder and kidneys. Thus, very slight obstructions at the bladder neck may cause retention of urine, stone formation, and sometimes undue irritability of the bladder. Similar slight and unsuspected obstructions of the ureter may cause congestions of the kidney, which, though they may be but slight or temporary, may happen at a time when the presence of bacteria in the blood offers the occasion for renal infection. Crabtree's case cited above is a very good example of how temporary even an acute infection of the kidneys may be. If we are to find in the theory of retention a cause for the infection of the right kidneys of little girls, we must seek it in some congenital condition. Let it be understood that the following theory is but a theory. Although it seems at the present moment the most likely explanation of obscure infection of the kidney, it is no more than this, but until some better theory supersedes it, we may take the liberty of expounding it directly as though it were an established fact, since this simplifies the exposition. Renal mobility is discussed in Chapter 45. Therein will be found an exposition of the theory of Volkow and Delitzin, which pretends to explain by a study of the anatomical shape of the niche in which the kidney lies, why this niche, being shallower in women than in men, and on the right side rather than on the left, makes the right kidneys of women more liable to mobility, as indeed we clinically know they are, than their left kidneys or than either kidney of a man. It is to be noted further that in many instances the position of the body determines whether the kidney shall be mobile or not, and that children may be trained to hold themselves in such a way that their kidneys shall not become mobile when they reach adult life. Thus, although what might be termed the gross mobility of the kidney occurs in adolescence and thereafter, the beginnings of this mobility are congenital. Now, it is well known that the grossly mobile kidney encourages inflammation and does so by virtue of kinking of the ureter, whereby a moderate or temporary retention occurs in the kidney, which may, under exceptional instances, reach an intensity shown by the complete retention of Dietl's crisis or of intermittent hydronephrosis. The same conditions exist to a lesser degree in little children, but it is to be remembered that little children are much more subject to infections of all sorts than adults. Their immunities are undeveloped by contact with infection. Doubtless, their kidneys share this lack of immunity, and doubtless, therefore, the kidneys of infants are more readily infected than those of adults. This combination of unusual susceptibility to infection and tendency to mobility explains, we believe, the infection of the kidney in children, and more particularly, the infection of the right kidney in little girls. The only other theory that has been seriously advanced to explain this condition is that the vagina of little girls is often infected with colon bacilli from the rectum, that the urethra of little girls is short, that they often have incontinence of urine, and that under these conditions the Bacillus coli readily invades the bladder and then the kidneys. But all our experimental evidence points to the fact that no infection can result from the invasion, either of the bladder or of the kidneys, by colon bacilli or by any other pathogenic bacteria, unless there are accessory causes of infection at work. Renal mobility is the most plausible accessory cause. Whether in the presence of renal mobility, a short urethra, or an infected vagina, or incontinence of urine helps to infect the kidney, we do not know. It seems rather more probable that the infection is usually derived from an inflamed colon. A third theory of infection, which would infect the right kidney directly from the lymphatic connection with the hepatic flexure of the colon, would be difficult either to prove or to disprove. But since it does not explain the frequency of this condition in little girls, we may neglect it. Most acute infections can be considered in terms of retention. Even stone and tumor often excite infection, not less as foreign bodies that obstruct the outflow of urine than they do as a breeding ground for bacteria or a source of surface irritation. Ureteral obstruction is usually unilateral. It may be due to obstruction within the ureter, e.g. stone, tumor, blood clot, stricture, to angulation of the ureter, e.g. nephrotosis or traction by tumors within the pelvis, or to pressure from without, e.g. by the pregnant uterus, by carcinoma, by appendicle or other abscesses, etc. Urethral retention causes infection of bladder and both kidneys. The infection may, however, be mild in one kidney, acute in the other. The acute infection may have for its accessory cause only the urethral retention, but there may arise a secondary ureteral cause of retention, such as a kink. In order to relieve such renal retention, it is necessary to relieve not only the urethral, but also the ureteral obstruction. The one flaw in this mechanical theory of renal infection is the infection of the opposite kidney. Not only is pyelonephritis almost always bilateral, but acute infection of one kidney is almost always associated with mild infection of its fellow. This mild infection of the opposite kidney is doubtless due to toxic rather than to retentive causes, as described below.